The subcommittee will come to order. Chair will recognize himself for an opening statement. Today, the subcommittee will consider 12 bills to improve treatment for opioid abuse, report on infants suffering from neonatal abstinence syndrome, update best practices for pain management and prescribing pain medicine, allow for co-prescribing of opioid reversal drugs, expand access to medication-assisted treatment, ban the sale of DXM to anyone under 18 without a prescription, study the dangers of opioid abuse in treating sports-related injuries, develop standing orders for naloxone prescriptions, clarify when prescriptions can be partially filled, encourage abuse deterrent technologies for opioids, and request a GAO report to Congress on substance abuse treatment availability and infrastructure needs throughout the U.S. As many of you know, one of this subcommittee's top priorities has been helping and protecting children and families. These bills that are the subject of today's markup represent our ongoing effort to work together to strengthen public health and address problems in our nation's healthcare system. In my home state of Pennsylvania, 1 out of every 4 households is affected by addiction. More than 2,400 Pennsylvanians died from overdoses last year, making it the leading cause of accidental death in our Commonwealth. According to the Centers for Disease Control and Prevention, the CDC, about 120 Americans on average die from a drug overdose every day. Overall, drug overdose deaths now outnumber deaths from firearms. More than 4 million Americans abuse prescription drugs or painkillers. Another 517,000 reported past year heroin use, a 150% increase since 2007. These facts are shocking, but they reflect the reality right in our neighborhoods. It is happening to Democrats and Republicans, to people of every race and religion. It happens to our friends, family members, and neighbors. We all know someone, and we share their pain. Today, we have legislation before us that will begin to address the addiction crisis we face. In 2015, the Energy and Commerce Committee's Oversight and Investigations Subcommittee held 5 hearings on the drug abuse crisis. In October, as chairman of the Health Subcommittee, I chaired a 2-part hearing at which we heard from experts like the administration's drug czar, Michael Botticelli, and Dr. Kenneth Katz of the Lehigh Valley Health Network. We discussed several proposals that would improve federal public health policies and help addicts get treatment. Each of these bills deals with a different aspect of the epidemic because we need a comprehensive plan, not just adequate funding, but targeted funding, not just emergency response, but education and prevention. These bills would make a number of changes to existing law. They would responsibly expand the number of practitioners who can provide medication-assisted treatment to patients, develop best practices and a national awareness campaign, ban certain drugs to youth without a prescription, help pregnant women who are addicted, request a report from GAO on the state of our substance abuse treatment availability and infrastructure needs. Congress will take action on behalf of the families and communities across Pennsylvania and the rest of the country being shattered by this public health crisis. I want to thank the sponsors of each of these bills for their diligent work thus far. These bills address a complex epidemic, and I know that after the subcommittee consideration today, the work will continue. I support each of these bills and urge their adoption by this subcommittee, and I yield back the balance of my time and now recognize the ranking member, gentleman from Texas, Mr. Green, 5 minutes for his opening statement.
Thank you, Mr. Chairman. It's been more than a decade since Congress passed legislation to address the addiction and drug use. Today, we're marking up 12 bills to enact a multi-pronged, broad response to the opioid and addiction epidemic Our response to this crisis requires all hands-on-deck effort, and I'm pleased to support these thoughtful bills. Together, they will provide enhanced and expanded prevention, treatment, and recovery programs for patients and families suffering from addiction. Prescription drug abuse is a growing national epidemic. Addiction, overdoses, and deaths involving non-medical prescription drug use, especially pain relievers, have risen dramatically over the last decade. According to the Centers for Disease Control, more people died from drug overdose in 2014 than in any year on record. The majority of drug overdose deaths involve an opioid. Since 1999, the rate of overdose deaths involving opioids, including prescription drug relievers and heroin, nearly quadrupled. From 2000 to 2014, 500,000 people died from drug overdoses. 78 Americans die every day from opioid abuse. There is not a person in this room who doesn't have a personal connection, constituent, or heartbreaking story of someone affected by this epidemic. It's happening in every single community. It's happening in Texas and across the country. We must face the opioid epidemic head-on, and today's subcommittee votes on bipartisan solutions marks an important step forward. The bills we're considering today rightly treat addiction like the public health crisis it is. The Nurturing and Supporting Babies Act will enhance our understanding of neonatal abstinence syndrome to remove barriers for treatment and prevention of NAS, which has hurt too many infants and their families. We're considering legislation to establish an interagency task force to devise and disseminate best practices for chronic and acute pain management. The Co-Prescribing to Reduce Overdoses Act will establish a grant program for co-prescribing overdose reversal drugs to high-risk patients, expanding access to life-saving treatments. The Improving Treatment for Pregnant and Postpartum Women Act will continue residential treatment programs for women and support family-based services for women with substance abuse disorder, including opioid addiction. The Veteran Emergency Medical Technician Support Act will streamline the licensure requirements for veterans who have been successfully completed military emergency medical technician training and want to serve as civilian EMTs. The Opioid Use Disorder Treatment Expansion and Modernization Act will expand access to medication-assisted treatment so that more patients can access the full scope of evidence-based services while minimizing the potential for drug diversion. The DXM Abuse Prevention Act will ban the sale of over-the-counter drug containing DXM to individuals under 18 unless they have a prescription. The James Thomas Decker Act directs the CDC to study and report information and resources available to young athletes and their families regarding the dangers of painkillers and how to seek addiction treatment. Layla's Law will allow states to develop standing orders for Naloxone prescriptions and educate health care professionals regarding the dispensing of overdose reversal medication without person-specific prescriptions. The Reducing Unused Medications Act will clarify when a prescription for a drug listed on Schedule II of Controlled Substances Act may be partially filled. The Opioid Review Modernization Act will codify the FDA action plan on opioids. This will mean better labeling decisions, new recommendations for prescriber education programs, and encouraging the development of new drugs with abuse deterrent properties. The Examining Opioid Treatment Infrastructure Act requires a review on substance abuse treatment facility and infrastructure needs throughout the United States, which we know is insufficient to meet our nation's needs. I want to thank all the bill sponsors and the Ranking Member Pallone, Chairman Upton, and Chairman Pitts for their commitment and leadership on this issue. While I urge swift passage of these bills, our work is not done. We need to provide real funding for this effort to ensure agencies have the resources to implement their provisions, and thus real Americans can get the help they desperately need. Thank you, Mr. Chairman. I yield back.
Chair, thanks, gentlemen, and now recognizes the Chairman of the full committee, Mr. Upton, 5 minutes for his opening statement.
Well, thank you, Mr. Chairman. Before I start, I just want to take a moment to thank every member on both sides of the aisle. I want to say that I think I've spoken to every member here about this issue and their concern as they reflect their representation from their state and the sincerity of why we really do need to take bipartisan action. I thank them for that, and I'm pleased to say that we, in fact, are doing the Lord's work by moving these bills today. You know, every 12 minutes, somebody dies of a drug overdose in the U.S. That means someone has already passed away just since we started this subcommittee hearing a few minutes ago. So it's pretty frightening. And we've got to face the epidemic head on, and that's why this subcommittee markup is such an important step forward. Addiction to opioids often progresses to heroin abuse, and the disturbing trend of growing addiction, emergency room visits, and death are tearing apart families and communities, not only in Michigan, but certainly across the country. Opiate-related overdoses have become the #1 cause of injury related to death in Michigan as well as nationwide, and it's hit most of my counties pretty hard. I know, and we've lost some pretty good kids. In recent years, we lost a young 18-year-old, Amy Boycefield, a graduate of Portage Central High School, and Marissa King, a 21-year-old who began using heroin despite having lost 2 friends to the drug, including Amy. And the epidemic does not discriminate. We know that. So we have to band together, take what we've learned to begin to make some changes that move us forward. The numbers are staggering. CDC and prevention reports that nationally nearly 260 million opioid prescriptions were written in 2012. That's 1 for every single U.S. adult, with 20 million to spare. And according to the director of the National Institutes on Drug Abuse, Americans consume 80% of the world's prescriptions of opioids. Yet we only represent, as we know, less than 5% of the population. So what makes us so different? Well, over the past year, we've held lots of hearings in both health and oversight with dozens of witnesses. And we've met with the experts, stakeholders, individuals in recovery, family members, for sure. Opioid addiction is a chronic disease of the brain and can be treated. Unfortunately, only about 10% of the 23 million folks suffering from alcohol and drug addiction get any form of treatment. And of the 10% who do receive it, less than 20% receive evidence-based treatment. In the past, too often federal policy towards opioid addiction has underemphasized the public health. No, we don't want to simply arrest our way out of the problem. That's not the answer. So we're here today to try and do something about it, marking up nearly a dozen bipartisan bills that touch on the spectrum of issues driving the opioid crisis and general drug abuse. 2 of the bills help expand access to naloxone, a life-saving overdose reversal drug. We've also got a bill that's going to expand access for pregnant and postpartum opioid-addicted women and their children. Another is going to make it easier for our vets returning from a tour of duty to translate the skills that they honed on the battlefield to working and volunteering on our EMT squads across the country. And I heard from some of those folks just this morning. Members on and off this committee have brought forward a number of good bipartisan ideas that we're going to advance in this subcommittee. While there's no one solution to the growing epidemic, the bills before us today represent good steps in addressing the problem that is affecting every community, everyone, and countless families across the country. So this subcommittee is going to do important work today, and the full committee is going to act as early as next week to keep the ball moving forward. And we look forward to having these bills on the House floor literally the first week that we're back in May. I yield back.
Chair, thanks, gentlemen. And now I recognize the gentleman from New Jersey, Ms. Plone, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. Today, we are meeting to mark up a number of different pieces of legislation related to the opioid abuse epidemic facing our nation. We've all come to know just how widespread and devastating this epidemic is. Opioid addiction is an indiscriminate killer. Americans, young and old, rich and poor, of all races and genders and from all regions of the country, are losing the fight against addiction. Back home, about 256,000 New Jersey residents are addicted to heroin or prescription opioids. That's nearly the same as the entire population of Newark, the largest city in New Jersey. And New Jersey is not alone in this crisis. We know that nationwide prescription opioid abuse has skyrocketed. Between 1999 and 2010, the death rate from prescription opioids more than quadrupled. In fact, every day, 78 families lose a loved one lost too soon due to an opioid-related overdose death. It's important that we approach this issue as a public health crisis and work to get people the care they desperately need. I'm particularly concerned about the current gaps in access to treatment. There are serious barriers to treatment that must be addressed, such as a shortage of substance abuse providers, a lack of counseling and support services, and the pervasive stigma related to receiving treatment. I believe that if we do not address these issues in a comprehensive manner, we will continue to see overdose deaths and related outbreaks of HIV and hepatitis C increase. The bills being considered today address a range of issues related to the opioid epidemic. I strongly support these bipartisan legislative efforts to expand access to substance abuse treatment services, increase access to overdose reversal medication, improve provider education, and increase public awareness of the problems of substance abuse. However, while these are important steps forward, I want to make clear that I don't think these efforts are enough. There is an urgent need to dedicate increased federal funding to help our communities combat this crisis, and I am disappointed that Congress has failed to provide resources proportionate to the severity of this crisis. Congressional Republicans continue to reject calls for increased resources, including President Obama's request for a new two-year, $1.1 billion mandatory investment to expand access to treatment for opioid addiction and close the treatment gap. Given my colleagues' unwillingness to spend any significant federal resources, we have tried today to identify statutory and regulatory changes that promote expanded access to treatment and recovery services. The policy that provides the best opportunity to expand access to treatment services without new federal funding is legislation to lift the cap on the number of patients that providers can treat with I always pronounce it wrong, with buprenorphine. Buprenorphine is a highly effective, evidence-based treatment for opioid addiction. However, currently doctors are only permitted to prescribe buprenorphine to up to 100 patients, resulting in patients who are on wait lists and cannot access treatment immediately. As with many medical conditions, timely access to treatment for opioid use disorders is absolutely crucial, and delays can meet dangerous opportunities for relapse, overdose, and even death. The statutory and regulatory regime governing buprenorphine is outdated, anachronistic, and is hampering our response to our national crisis. We're asking doctors on the front lines battling this crisis to do so with one hand tied behind their backs. We have a responsibility to the individuals, families, and communities that are being shattered by opioid addiction to do everything within our power to combat the current crisis. While HR 4981 makes an important step towards fulfilling that goal by raising the buprenorphine cap to 250 patients and providing prescribing authority to nurse practitioners and physician assistants, I think we can and should go further, and I strongly urge my colleagues to support a higher cap than the one included in this legislation, and I will be introducing an amendment during the markup to accomplish this. I'm sure most of us here can recall the heartbreaking story of a friend, family member, or constituent struggling with substance abuse. We owe it to these individuals and their families to do everything we can to pass meaningful legislation, provide adequate resources, and put a stop to the epidemic. Although I wish the legislation we're considering today provided more resources to address this problem, I'm pleased that we're meeting today to consider these important bipartisan efforts, and I look forward to further action. So thank you, Mr. Chairman. I yield the balance of my time.
Chair, thanks to gentlemen. Chair reminds members that pursuant to the committee rules, all members' opening statements will be made part of the record. Are there further opening statements? The gentleman from Kentucky, the vice chairman, is recognized for 3 minutes. No opening statement. Are there any other opening statements? Dr. Murphy is recognized for 3 minutes.
Thank you, Mr. Chairman. We all know we're in the throes of an opioid crisis, and to help address this, I know we're going to move several important bills here. I had prepared a list of 10 different amendments based upon the bipartisan work of the Oversight and Investigation Subcommittee over the last 2 years. I will not be offering all the amendments today because I have assurances from committee leadership we'll be working to address these concerns between subcommittee and full committee. But I did want to mention them quickly here, including keeping the buprenorphine prescribing cap at a level where treatment can be provided with the aim of recovery, enhancing the requirements that patients receive buprenorphine received evidence-based addiction counseling. Amending the 42 CFR Part 2 said highly diverted drugs like buprenorphine are included in a prescription drug monitoring program like NASPR, allowing patients to voluntarily share their substance abuse treatment records with primary care and physical health providers, studying how pain metrics on patient satisfaction surveys that are tied to payments for hospitals are actually contributing to increased rates for opioid prescribing pain medication, expanding our understanding of how the institution of mental disease exclusion has decreased access to inpatient and residential treatment for substance abuse disorders, thus limiting evidence-based treatment options for individuals trying to recover from addiction. Ensuring that we are working upstream to prevent an overdose and a priority to help addicts recover and refrain from using dangerous drugs instead of simply expanding access to naloxone. I have a tremendous amount of admiration for the members of this committee who are working on these issues, and I want to continue to work on this, but on such things as dealing with medication-assisted therapy. The evidence that we've seen in the Oversight and Investigation Committee clearly told us that it has to be accompanied with wraparound services and counseling, since that is how clinical intervention is defined by SAMHSA, and that just having medication-assisted treatment alone and assurances that someone will seek treatment isn't enough. Our statistics in Pennsylvania, Mr. Chairman, you cited them. They're bleak. It's getting worse. And while we see improvements in mortality rates for cancer, auto accidents, so many other areas, we see continued mortality rates climb with regard to drug abuse. We can't continue this. But let's keep this in mind. Many addicts are master manipulators of physicians, of families, and friends. Their addiction is more powerful than their care for their own life or love of family, and many will lie to the doctor and steal from their family and take food from their children to feed their addiction. If it was as easy as putting the solution in front of an addict and saying, could you please sign this and say you'll get treatment, they would all be cured. So I just want to make sure this committee is very careful as we wade into this area. We as a committee cannot become enablers and allow ourselves to be lulled into the belief that because we are doing something, we are doing the right thing. For decades, Congress has failed to address the issue of drug abuse, treating it as a crime, and rewarding doctors who overprescribe opioids. I'm grateful this committee is addressing this head-on, and I look forward to continuing to work with the committee leadership between now and the full markup so we can have a meaningful bill presented before the House, and I yield back.
Chair thanks, gentlemen. Now recognize the gentlelady from Illinois, Ms. Schakowsky, 3 minutes for opening statement.
Thank you, Mr. Chairman. There's no question that we are in the midst of an opioid abuse epidemic. There's not a member here whose district has not been touched by it. That's why I'm so glad that we're here today to work on how we can better combat the growing problem. The bipartisanship is really great. One of the most important things we can do is expand access to medication-assisted treatment. Currently, we have thousands of people across this country on waiting lists to access medication-assisted treatment because of the current caps we have on prescribing and the limited number of providers who can prescribe. And at the same time, we have people dying of opioid overdoses every day. So I strongly support increasing the number of patients a doctor can prescribe buprenorphine to, I thought I had it down, buprenorphine to, and I also strongly support allowing physician assistants and nurse practitioners to prescribe buprenorphine, and I'm pleased that the legislation we're considering today allows for both. Currently, nurse practitioners and physician assistants can prescribe opioids, which we know are at the heart of the epidemic and are so often abused, yet we do not allow nurse practitioners and physician assistants to prescribe the medication used to treat opioid addiction. The Opioid Use Disorder Treatment Expansion and Modernization Act will correct this problem. I'm proud to support it. I also strongly support H.R. 3691, the Improving Treatment for Pregnant and Postpartum Women Act, and I'm pleased that we're expanding this program to increase funding for outpatient services. Pregnant and postpartum women who are seeking addiction treatment have unique circumstances, and the treatment they receive needs to be cognizant of that. They often are unable to enter into an inpatient rehab program because they have children at home, so we need to be sure that they have treatment options that work for them and their families. And finally, while I support the bills we're considering today, I also believe we need to have a serious conversation about increasing funding for addiction treatment. There is no question that we have an access problem when it comes to treatment, and every single day, addicts who want help are unable to get it because there simply aren't enough treatment centers. I look forward to working with my colleagues on this committee to continue to find ways to combat the growing epidemic of opioid abuse and to include more direct treatment. Thank you.
Chair thanks the gentlelady. Does anyone seek recognition on the majority side? Does anyone seek recognition on the minority side? If not, the chair now calls up H.R. 4978 and asks the clerk to report.
H.R. 4978, to require the Government Accountability Office to submit to Congress a report.
Without objection, the first reading of the bill is dispensed with. The bill will be open for amendment at any point. So ordered. Are there any bipartisan amendments to the bill? Are there any other amendments to the bill? I'll recognize myself to speak briefly on the bill. The Nurturing and Supporting Healthy Babies Act was introduced by the gentleman from West Virginia, Congressman Evan Jenkins, to help us fully evaluate the rate of neonatal abstinence syndrome, NAS, within Medicaid. Neonatal abstinence syndrome is a serious condition that affects infants whose mothers have taken a large amount of opioids during pregnancy. I'm hopeful that this bill will allow us to fully evaluate the current gaps in services for babies suffering from neonatal abstinence syndrome. This legislation builds off of the good work our committee has undertaken on the NAS, H.R. 1462, the Protecting Our Infants Act, which has been signed into law. That legislation studies how we can prevent and treat prenatal opioid abuse and NAS more broadly. So I urge my colleagues to vote yes on this legislation. The question now occurs on forwarding H.R. 4978 to the full committee. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is agreed to.
This is next.
The next bill is H.R. 4641, and the chair calls up H.R. 4641, asks the clerk to report.
H.R. 4641, to provide for the establishment of an interagency task force.
Without objection, the first reading of the bill is dispensed with. The bill will be open for amendment at any point. So ordered. Are there any bipartisan amendments to the bill?
And Mr. Chairman, I move to strike the last word.
Who is seeking recognition? The gentlelady from Indiana is recognized for 5 minutes.
Mr. Chairman, it's clear from the scope of the bills that were about to be discussed that the spike in opioid and heroin abuse directly impacts every district across the country. And we know that the current opioid and heroin epidemic's making headlines nationwide, and I've heard as recently as last week from Hoosiers about the personal and tragic impacts this epidemic is having on families. In Indiana alone, from 1999 through 2009, health officials saw a 500% increase in the rate of drug overdose deaths. This epidemic didn't happen overnight, and it's not going to be resolved overnight. It's impossible to point to one specific reason for why it spiraled out of control to a point where in Indiana and across the country, overdose deaths now are surpassing motor vehicle-related deaths. But the one thing we do know and that we have learned is that about 80% of all heroin addicts started down that road with an opioid prescription. Providers across the country in my home state in Indiana are working to stem this tide, and I applaud them for that. Through conscious efforts to crack down on overprescribing in one of my counties, Grant County, Marion General Hospital successfully dropped the number of pain prescriptions written over the past year by 100,000 pills in 1 year. This is one example of the efforts of those on the front lines of this epidemic undertaking to fight back against it. prescribing physicians, pharmacists, first responders, law enforcement, and most importantly, family members of addicts are working in our communities every day, and we must ensure they have the best guidance, support, and resources to be successful. In drafting prescriber guidelines for pain medication, the CDC has taken a significant step to support prescribers. They understand that the overprescription of opioids is a serious problem and that clear guidelines for prescribers need to be implemented to help address our nation's growing heroin and opioid abuse crisis. H.R. 4641, which I introduced with our colleague Representative Kennedy, would examine these guidelines and ensure that opioid prescribing practices are reviewed, modified, and updated where needed by an interagency task force and expert stakeholders from the prescriber, patient addiction, and recovery community to reflect best practices going forward. I'm grateful that our leaders, Chairman Upton and Pitts, Ranking Members Pallone and Green, recognize the seriousness of this epidemic, and I look forward to consideration in the House of this and all of the other solutions that we have to help providers and patients stem the tide of the opioid abuse. With that, I yield back.
Chair, thanks, gentlelady. Are there amendments to the bill? The Chair recognizes Mr. Kennedy to offer an amendment.
Thank you. Thank you, Mr. Chairman. I have a bipartisan amendment at the desk.
Which one? Clerk, read the amendment.
Amendment to H.R. 4641 offered by Mr. Kennedy.
Thank you.
The gentleman's recognized.
Thank you, Mr. Chairman. One thing that has been very clear in this committee and that this entire body is that combating opioid abuse disorders transcends a partisan divide. I've been fortunate to work very closely with Congresswoman Susan Brooks on this issue over the past few years. As former prosecutors, we both have seen the way that addiction leads too many in our justice system rather than into the treatment that they so desperately need. But we also knew that in talking to our constituents, that few families and communities have been spared the heartbreak of addiction, and that any effort to combat it will require all of us, from advocates to treatment specialists to law enforcement to families. And that's why we've introduced this bill. By convening a task force that includes experts in numerous agencies, backgrounds, specialties, we can replicate the best practices across the country, avoid repeating our shortcomings, and develop a strategy to increase access to treatment for all Americans battling substance use disorders. So I urge my colleagues to support this legislation. The amendment that I've offered along with Representative Brooks is a simple bipartisan amendment that would expand the list of task force members to include the Substance Abuse and Mental Health Administration and Indian Health Services. It's my understanding that staff continue to discuss other possible additions to the list of task force members, and the conversations will continue as this legislation moves to the full committee. I urge my colleagues to support this amendment and to ensure the task force is as robust as possible and includes the views that we all need in order to get to the right answers on a very difficult topic. And I yield back.
Chair, thanks, gentlemen. We will support this amendment. Does anyone else seek recognition on the amendment? If not, the question now occurs on forwarding H.R. 4641 as amended.
Chairman.
No, we're not ready yet. We've got more.
Yeah.
Chair recognizes gentleman, Mr. Griffith, for offered amendment.
Thank you very much, Mr. Chairman. I actually want to strike the last word for the purposes of the colloquy with Representative Brooks and yourself or Chairman Upton. That may be.
Gentleman's recognized.
Thank you, Mr. Chairman. I had thought about introducing an amendment today, but decided that it would probably be better to hold off and see if we could work something out before the full committee. The amendment is a simple one. Its intent is to reassert the authority of the legislative branch as a co-equal branch of government. If we are creating a task force, advisory board, or commission that is ultimately reporting back to Congress, I think congressional appointees should be represented in the discussion so that it doesn't come as a complete surprise when the group comes out with their report. We did that with some congressional appointments as a part of the advisory board within the 21st Century Cures. And I came from the Virginia legislature where I served for many years, and we did that as a commonplace there. It worked very well. It was bipartisan. And so what I would propose is that we have a 3-2 split in the House and a 2-1 split in the Senate. Other configurations may work between the majority party and the minority party. Appointments can be delegated by the leadership to the chairman and ranking member of the Committee of Jurisdiction if that is their wish. This is the kind of the idea. And over time, it's a slow process and a steady project that I think we should work on to make sure that we have a voice in a lot of the behind-the-scenes things that are going on, so we're not waiting a year and a half, a report comes out, and all of a sudden we go, well, that's crazy. We have some congressional appointees. They'll be talking with us. We'll be talking with them. And as working in a partnership, as a part of the task force or having appointees on the task force, I think we can do great things. I will yield to Representative Brooks or Chairman Pitts or Chairman Upton, whoever might want to speak on this matter, in hopes that we can work together to include legislative appointments to the task force before we get to the full committee workup.
Chair recognizes Ms. Brooks.
Thank you, Mr. Chairman. I do have a question. Learned about this yesterday to the gentleman from Virginia. And originally when it was brought to me, I was under the impression that it was a member of Congress, but you're actually interested in an appointee, someone with actual expertise in the area of prescribing that Congress would appoint, not that it would specifically be a member of Congress. Would that be correct?
That is correct. However, if there was a specialized area, as I look at the broad picture, if we wanted to make it a member of Congress, I'm not against that, but generally speaking, members of Congress from across the United States have lots of things to do, and I'm not trying to add to that, but have experts in the field who are representatives of each of the legislative branches, Congress and the Senate, and so that we have some input while the process is going on instead of being left in the dark and then all of a sudden proposals come out. But that is the concept, but it can work either way.
Thank you. I look forward to working with the gentleman from Virginia on this concept moving forward. I think it definitely has merit, and seeing that it was involved or included in 21st Century Cures, I think it could have merit with this bill as well.
Thank you very much.
That concludes the colloquy. We're still on the Kennedy Amendment. Does anyone else wish to speak on the Kennedy Amendment? If not, we will vote now on the Kennedy Amendment. The question now occurs on amending 4641 with the Kennedy Amendment. All those in favor say aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the amendments.
Are there other amendments?
The amendments adopted. Are there other amendments to 4641? If not, the question now occurs on forwarding H.R. 4641 as amended to the full committee. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is agreed to.
Give it to me. This is next. There are two amendments.
Okay, the chair now calls up H.R. 3680. Co-Prescribing to Reduce Overdoses Act, and ask the clerk to report.
H.R. 3680, to provide the Secretary of Health and Human Services to carry out a grant program for co-prescribing opioid overdose rehearsal drugs.
Without objection, the first reading of the bill is dispensed with. The bill will be open for amendment at any point, so ordered. Are there any bipartisan amendments to the bill? Chair recognizes the gentleman, Mr. Sarbanes from Maryland. Offer amendment.
Thank you. Thank you, Mr. Chairman. Have an amendment at the desk, technical amendment.
Clerk will report.
Amendment to H.R. 3680 offered by Mr. Sarbanes.
The gentleman's recognized. 5 minutes.
Thank you, Mr. Chairman. I want to thank ranking members Pallone and Green, as well as yourself, Mr. Chairman, and Chairman Upton for working diligently with me and my staff so we could bring this bill to the markup today. And I also appreciate the support of Representative Bouchon from the other side of the aisle. I'm pleased to offer this amendment that will essentially make some technical changes to the bill that were previously agreed to by both the majority and minority, and reflects some technical assistance that we received from HHS during this process. This bipartisan bill, the Co-Prescribing to Reduce Overdoses Act, would create a demonstration project to encourage prescribing opioid overdose reversal drugs like naloxone to patients at an elevated risk of overdose, as well as to a close relative of such a patient. Mr. Chairman, as you and members of the committee know, this has reached epidemic proportions, the opioid addiction crisis. More than 100 Americans die every single day to preventable drug overdose, and overdose fatality is now the leading cause of accidental death in the country. In 2014 in Maryland, 578 people died due to heroin, compared with 464 the year before. In Baltimore, my hometown, 303 people died from drug and alcohol overdoses in 2014, 192 of them as a result of heroin. This was a 19% increase from 2013. This is more than the number of people who died of homicide in the city. And in Anne Arundel County, which I also represent, 360 opioid overdoses, fatal and non-fatal, of which 49 were fatal. 16,000 people in 2013 died due to prescription opioids overdose, and an additional 8,000 died due to heroin overdose. And the problem's getting worse, as we know. This is an epidemic, but it's an epidemic that we can begin to stem with bills such as this and many of the others that are being proposed today. Naloxone is a drug that safely and effectively reverses both opioid and heroin-induced overdoses if administered in time. It has been used by non-medical personnel. We've heard plenty of testimony about this, with only minimal training for over 15 years, and has been proven to lower overdose mortality by almost 50%. More people need access to this life-saving medication. And while efforts to distribute naloxone to first responders and community organizations are critical and important, we also have to take a more proactive approach. One part of that approach addressed in this bill is the idea of co-prescribing naloxone to patients or to their caregivers who are taking opioids and are at high risk of overdose. This is supported by the American Society of Addiction Medicine, the American Medical Association, and the Veterans Health Administration. The bill before us today would create a demonstration project for federally qualified health centers, opioid treatment centers, and other providers to encourage co-prescribing naloxone. Funds could be used for training, to purchase opioid overdose reversal drugs, to offset co-pays, to conduct community outreach and raise awareness, to connect patients who have experienced a drug overdose with appropriate treatment, and to track individuals participating in the program. All grant recipients would be required to evaluate the outcomes of the program. I'm extremely pleased to see this bipartisan bill move forward today, because I know that this will save lives and help begin to stem the tide of this terrible epidemic. This bill has been endorsed by the AMA, the American Society of Addiction Medicine, and the Harm Reduction Coalition. There are two Republican co-sponsors, Representative Bouchon, who I mentioned, from Indiana, who serves on this committee, and Representative Randy Hultgren from Illinois. We'd certainly welcome additional support, and I urge my colleagues to support this amendment to the bill and the underlying bill. I yield back.
Chair, thanks, gentlemen. Again, we support this bipartisan amendment. Are there anyone else seeking recognition on the Sarbanes amendment? If not, the question now occurs on adopting the Sarbanes amendment to 3680. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have, the ayes have it, and the bill is agreed to. Are there any other bipartisan amendments to the bill?
Mr. Chairman?
I'm sorry, who is seeking recognition?
Over here.
Mr. Engel?
Thank you. Mr. Chairman, I just want to very briefly move to strike the last word. I had an amendment to the previous bill, which contained the text of H.R. 3119, the Palliative Care and Hospice Education Training Act, which I introduced last year with Congressman Tom Reed of New York. And I just want to say that palliative care is interdisciplinary, patient and family-centered health care that focuses on providing relief from the pain, symptoms, and stress of a serious illness. Its goal is to alleviate suffering and improve quality of life for patients and their families. One of the main goals of my bill is to expand training opportunities for healthcare providers in palliative care and specifically pain management. And I'm raising this issue today because I feel that better provider training in pain management needs to be part of our response to the opioid crisis. To truly tackle high rates of opioid abuse and addiction, we must make sure opioids are being prescribed responsibly and according to the Substance Abuse and Mental Health Services Administration. There was a fourfold jump in the prescribing of opioids for pain treatment between 2000 and 2010. And sadly, during the same period, rates of opioid abuse and addiction similarly skyrocketed. and the prescription opioid death rate in the U.S. has more than quadrupled since the late 1990s. In 2013, prescription opioids played a role in more than 16,000 overdose deaths, and nearly 2 million Americans grappled with opioid abuse or dependence. And as we work to combat this epidemic, it will not be enough to respond to addiction. We must simultaneously work to prevent it by affording the healthcare workforce robust training on pain management, including how to prescribe opioids safely. Let me also say that Congresswoman Brooks and Congressman Kennedy's bill get to the heart of this need by making sure we have guiding principles in place to inform providers' decisions as they treat patients suffering from chronic and acute pain. So what I have done is take the added step of ensuring that we have the education center's curricula and teachers needed to improve provider training in pain management. And let me say in conclusion, we cannot hope to overcome this crisis without providing our healthcare workforce with the education and information necessary to prescribe opioids carefully, and that is exactly what my amendment would do. I'm not putting in an amendment. I just wanted to raise that, and I thank the chairman and the committee, subcommittee for its indulgence. Thank you, Mr. Chairman.
Chair thanks gentleman for his remarks. Are there other bipartisan amendments? The chair recognizes Mr. Griffith to offer an amendment.
Thank you, Mr. Chair. I believe there's an amendment at the desk.
Will report.
Amendment to H.R. 3680, offered by Mr. Griffith.
Chair recognizes Mr. Griffith, 5 minutes in support of his amendment.
Thank you very much, Mr. Chairman. Last year, I led a letter with 22 of our colleagues calling on HHS to develop best practices for the use of naloxone. This bill, with my amendments, codifies the request for best practices. My amendment takes bipartisan language developed by Senators Kane and Capito, calling on HHS to develop these best practices for prescribing naloxone to patients who are at an elevated risk of overdose for opioids or heroin. This would include those who may or may not be in treatment for opioid addiction. We incorporated technical assistance in the amendment from HHS to ensure these best practices do not cause liability concerns for our medical providers. Finally, there is no new expenditure associated with the development of these best practices, as HHS would develop those using existing authorizations. It is my hope that we will add this amendment to a very good bill.
Chair thanks the gentleman. Does anyone else seek recognition on the Griffith Amendment? Mr. Sarbanes?
I just want to thank the gentleman for the amendment. It's a sound and a constructive addition to the bill, and I support it. And with that, I yield back.
Chair thanks the gentleman. Dr. Murphy, seek recognition.
Thank you. I move to strike the last word. I have a quick question, if I can, for Mr. Griffith on this amendment, if I could. I know that one of the concerns I hear from the DEA and from other providers is that with naloxone out there, obviously it saves lives, and it's been great for first responders to have this with them. A couple things I've heard has raised concerns. One, in computing actual drug overdoses, in some cases, once a person is revived from naloxone, they refuse to go to the hospital, and so those numbers are never registered in terms of drug overdose rates. I don't know if this specifically addresses that, but that's something I think we ought to be looking at. The second thing we hear is from people who are highly addicted. They actually now will push themselves further in taking a dangerous drug with this distorted belief in their mind that this near-death experience is okay because I can take this, someone will have some naloxone around, and so I can take a bigger risk with that. I just want to make sure we're, in our educational process and dealing with this, we're aware, we're monitoring those numbers to also look at the effect that this may have. And I yield to the gentleman if you have any comments on addressing those.
I think both are points that ought to be reviewed. I think we should certainly get it out there in the field and see what happens over time. I mean, you're right, there are going to be some folks who do that, but the vast majority of folks who are overdosing aren't thinking of it in those terms. And, you know, I can't tell you it won't happen, but I do think it's something we should monitor. I think it's a very good point.
Well, I appreciate it, especially given the idea that once an addict is there, that's all they're concerned about is their addiction, and I appreciate it. Look forward to further conversations. Mr. Chairman,
Will the gentleman
yes,
yield?
you'll do, yes.
It's a fair concern, and it's something that I've looked into as we put the bill together. On your first point, I actually had the opportunity recently to be with some healthcare professionals in one of my counties who indicated that in these situations where somebody's being revived through naloxone after overdosing, what they're finding is that the family are immediately contacting health professionals to report that because it causes such alarm inside the family. And they're talking about, as part of a best practices, you might include providing information, an emergency hotline and so forth, with the naloxone so that people could immediately call and report that, so that it's, because at that point in time, that's the opportunity, the research shows, to have a person who's motivated with their family to move into a treatment program. And we understand that, just reviving somebody from an overdose, that's not the end of the process. It's really the beginning of the process. On your second question, there's a fair amount of studies that suggest that your concern, while valid, I think, is one that we recognize. There's a response to that. Naloxone actually causes acute withdrawal, which is very painful for individuals who are dependent on opioids. And it negates the purpose of taking the opioids. And there's a whole set of studies that have concluded that the availability of naloxone does not, in fact, encourage people to use more drugs or to use them in riskier ways. And those are some studies that we can certainly provide to you going forward.
I appreciate the gentleman's comments. Perhaps one of the things we can do is see if there are some practice guidelines that can be written along with this to make sure we're monitoring those, and I appreciate
I think it's a
the
good
gentleman's
idea.
concern.
Will the gentleman yield for a
Yes.
second?
Yes.
Yeah, I'd like to just say, as someone who has given Narcan or naloxone to patients in the hospital, that it is very important that, that they do go to a hospital after they've been given naloxone. Number one, sometimes one dose is not enough and they rebound. Number two, there are side effects of a naloxone. I don't have them listed in front of me, but you should look that up. There can be problems with like you said, quick withdrawal. People also can become combative, tachycardic, a fast heart rate, and other things. So I just want to, I do think the concern about, patients that don't go to the hospital, that we need to make it very clear, and as part of our training process of first responders or others giving naloxone, that it is very important that those patients go to a medical facility after they've been giving it. And I would argue, even if it's given by a family member, family members need to understand that there are risks of not going to the hospital. I yield.
I appreciate the discussion just in the last 20 seconds because I think it points up the value of having a demonstration, a program like this, because we begin to explore some of the issues that we just talked about here. And
Thank you. I yield back, Chairman.
Chair, thanks, gentlemen. Does anyone else seek recognition on the Griffith Amendment? If not, the question now occurs on adopting the Griffith Amendment. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is agreed to. Does anyone else seek recognition on the amended bill? The question now occurs on forwarding H.R. 3680 as amended to the full committee. All those in favor say aye. Aye. Opposed, no. The ayes appear to have it. The ayes have it, and the bill is agreed to. All right. The chair now calls up H.R. 3691 and asks the clerk to report.
H.R. 3691, to amend the Public Health Service Act to reauthorize the residential treatment programs for...
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point, so ordered. Who's seeking recognition? Chair recognizes the gentleman, Mr. Lujan.
Mr. Chairman, motion to strike the last word.
Chair recognizes the gentleman.
Mr. Chairman and Ranking Member, our communities are hurting and our families face a substance abuse crisis that is tearing them apart. Illicit drugs like heroin and methamphetamine and prescription drug abuse have led to an epidemic of drug overdose. In 2 counties in my district in New Mexico, the overdose rate is more than 4 times the national average. Too many people are suffering and too many people are being forgotten. But it isn't just New Mexico. The crisis touches everyone, whether they live in rural communities, the suburbs, or the inner city. Millions of Americans, be it a brother or sister, a parent, or a close friend, know that the struggle of substance abuse is real. People need access to healthcare providers and doctors. Our citizens need access to medicine and care. But in too many communities in New Mexico and across the country, simply accessing life-saving resources and services can often be an impossible challenge. That's why I introduced the Improving Treatment for Pregnant and Postpartum Women Act, which will strengthen efforts to ensure that some of our most vulnerable pregnant and postpartum women and children get the care they need. And I encourage and appreciate the committee's support. I thank my many colleagues who have joined me in supporting this effort, Congressman Tonko, Congresswoman Clark, Congressman Matsui, and Congressman Cardenas. I believe that my bill and the many other bills we are considering today are an important step forward. And while no single solution will solve this crisis, one thing is clear. We must provide robust resources and support to those who want to get better. But right now, there just aren't enough resources to go around. For that reason, I'm already working with my colleagues to introduce new legislation that reflects President Obama's call for new and expanded funding of $1 billion to combat the heroin and opioid abuse crisis that is plaguing our country. I believe that the President's proposal represents a significant down payment to address this crisis. I hope we can make this legislation bipartisan. I look forward to working with my colleagues and hearing their ideas and those of the staff, because as we can see here, this effort requires a bipartisan coalition and innovative approaches that test new ideas. But it's time to recognize that in order to address this epidemic, we must have increased support. I look forward to continuing to work with my colleagues on this committee to provide assistance and relief to families and people in need across this country. And with that, Mr. Chairman, I yield back the balance of my time.
Chair, thanks, gentlemen. Anyone else seeking to speak on the legislation? Let me speak briefly on behalf of the bill. I'm pleased with the progress of H.R. 3691, Improving Treatment for Pregnant and Postpartum Women Act. The bill provides pregnant and postpartum women and their infants with family-based treatment to address a substance abuse diagnosis. And while my colleagues and I still have some cut-go issues to resolve, I believe this bill is a step in the right direction to provide expectant mothers and infants with necessary care in the case of substance abuse. So I urge support of the bill. And are there any bipartisan amendments to the bill? Are there any other amendments to the bill? If not, the question now occurs on forwarding H.R. 3691 to the full committee. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is agreed to. All right, the next bill, Chair calls up H.R. 1818 and asks the clerk to report.
H.R. 1818, to amend the Public Health Service Act to provide grants to states to streamline state requirements.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Are there any bipartisan amendments to the bill? Are there other amendments to the bill? Let me speak briefly in favor of the bill. No amendments? Yeah, no amendments. I want to speak briefly in favor of H.R. 1818, the Veteran Emergency Medical Technician Support Act. H.R. 1818 will allow military medical trained personnel to meet certain civilian emergency medical training licensure requirements. First responders play a key role in addressing the opioid crisis, and I believe this bill will allow more emergency medical technicians to serve our communities across the country. This bill has previously passed the House twice with large bipartisan support, and I urge my colleagues to vote yes on this legislation. Is there anyone else seeking? Ms. Capps is recognized to speak on the bill.
Thank you, Mr. Chairman. I move to strike the last word and also highlight the importance of H.R. 1818. I appreciate the chairman speaking in its favor. This is the Veterans Emergency Medical Technician Support Act. I've worked with Representative Kitzinger the past two Congresses on this issue. I'm pleased to see it up for discussion again today. You know, our men and women in the military receive some of the best technical training in emergency medicine anywhere, and this is while they're serving their country. But when they leave the military to return home, they're so often required to start back at square one to receive certification for civilian jobs. Similarly, military medics with civilian credentials, when they join the military, often must let their civilian certifications lapse while defending our country. Either way, this keeps our veterans out of the civilian workforce and deprives our communities of valuable medical personnel. Vets EMT is a small but very straightforward bipartisan bill to help states streamline their certification processes to take military medic training into account for civilian licensure. Similarly, similar legislation has passed the House, as you said, in previous Congresses. I'm hopeful we can continue to work together in a bipartisan way to get this bill into law. I believe we owe these talented professionals the opportunity to join our healthcare workforce and improve the care with their service in our community. And I yield back.
Chair, thanks, gentlelady. Anyone else seeking recognition on H.R. 1818? If not, the question now occurs on forwarding H.R. 1818 to the full committee. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is agreed to. The chair now calls up H.R. 3250 and asks the clerk to report.
H.R. 3250, to amend the Federal Food, Drug, and Cosmetic Act to prevent the abuse of dextromethorphan.
Without objection, the first reading of the bill is dispensed with. The bill will be open for amendment at any point, so ordered. Are there any bipartisan amendments to the bill? Are there any other amendments to the bill? Does anyone seek recognition on speaking on H.R. 3250? If not, the question now occurs on forwarding H.R. 3250 to the full committee. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is agreed to. All right, the chair now calls up H.R. 4969 and asks the clerk to report.
H.R. 4969, to amend the Public Health Service Act to direct the Centers of Disease Control and Prevention to provide for...
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Are there any bipartisan amendments to the bill? Are there any other amendments to the bill? If not, I would like to speak briefly in favor of the bill. This is the John Thomas Decker Act, H.R. 4969. The bill directs the Secretary to provide for informational materials to educate and prevent opioid addiction in teenagers and adolescents who are injured playing youth sports and then prescribed an opioid. One study found that adolescents and teenagers who played high-injury competitive sports and were prescribed an opioid had a 50% higher chance of non-medical use of prescription opioids than their peers who did not participate in these types of sports. I urge my colleagues to support the amendment and the underlying legislation.
There is one bipartisan amendment that we're offering.
All right, we are offering one bipartisan amendment, and I would like to ask clerk to report the amendment.
Amendment to H.R. 4969 offered by Mr. Pitts.
All right. I just read that.
It just makes technical changes.
Yeah. This amendment merely makes technical changes to the bill. Does anyone seek to be recognized on the amendment? If not, the question now occurs on the Pitts amendment. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is agreed to. Are there any other amendments to the bill? If not, the question now occurs on forwarding the Bill H.R. 4969 as amended to the full committee. All those in favor say aye. Aye. Those opposed, no. The aye appears to have it. The ayes have it, and the bill is agreed to. All right, the chair now calls up H.R. 4586 and asks the clerk to report.
H.R. 4586, to amend the Public Health Service Act to authorize grants to states for developing standing orders and educating healthcare professionals regarding.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. I have. Are there any bipartisan amendments to the bill? I have a bipartisan amendment that I will offer. Clerk will report.
Amendment to H.R. 4586, offered by Mr. Pitts.
All right. This is the Lolly's Law, H.R. 4586. The bill creates a competitive grant program that helps states increase access to naloxone, a life-saving opioid overdose reversal drug. Increasing access to naloxone through standing orders at pharmacies will get this critically important drug into the hands of more individuals at risk for overdose from opioids and their loved ones. So I urge my colleagues to support the amendment and the underlying legislation. Yield back. Anyone else seek recognition on this bipartisan amendment? If not, the question is on the bipartisan Pitts amendment. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill, or the amendment's agreed to. Is there anyone seeking recognition on the amended bill? If not, the question now occurs on forwarding H.R. 4586 as amended to the full committee. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is agreed to. The chair now calls up H.R. 4599 and asks the clerk to report.
H.R. 4599, to amend the Controlled Substances Act to permit certain partial fillings of prescriptions.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Are there any bipartisan amendments to the bill? Chair recognizes gentleman Mr. Kennedy to offer an amendment.
Thank you, Mr. Chairman. I have an amendment at the desk.
Clerk report.
Amendment in the nature of a substitute to H.R. 4599, offered by Mr. Kennedy.
Chair recognizes Mr. Kennedy. 5 minutes in support of this amendment.
Mr. Chairman, thank you. This is a bipartisan amendment in the nature of the substitute that essentially makes just some technical changes to the underlying legislation. I believe there's broad bipartisan support for the legislation. And I want to acknowledge my colleague from Massachusetts, Catherine Clark, who is one of the authors of this piece of legislation. Mr. Chairman, earlier this month, a young woman from my home state of Massachusetts named Kelsey Errico died of heroin overdose after a long fight with substance use disorder. Hoping to spare families from her same heartbreak, Kelsey's mother, Kathleen, decided to use her death as an opportunity to raise awareness about the devastating disease she faced. In Kelsey's death notice, her mother wrote, quote, "The disease of addiction is merciless. It is up to us to open our minds and hearts to those who are still sick and suffering. Kelsey does not want us to cry for her. She wants us to fight for her." Kelsey's story has become far too common in our Commonwealth. It's become far too common in Oregon, in Indiana, in West Virginia, and every other state represented on this dais today. In just 3 weeks last month, the county where I once served as a prosecutor experienced 20 overdose deaths, 2 of which were in the presence of children. And a recent study of opioid-related hospital visits in Massachusetts found that they had risen by nearly 200% between 2007 and 2014, from 31,000 to 57,000. More than just numbers, those are lives lost and families forever altered. That's why our delegation has been working closely on this issue over the past few years, and why I'm honored to offer the amendment in nature of the substitute of the Reducing Unused Medication Act, sponsored by my colleague, again, Congresswoman Catherine Clark. Almost exactly 2 years ago, our delegation helped raise awareness across our state for National Prescription Drug Take-Back Day, leading to nearly 23,000 pounds of unused medication collected in Massachusetts and 390 tons collected across the country. Thousands of patients who no longer needed those pills dropped them off and removed the risk of abuse and misuse by family members and friends battling addiction who might have found them. Passing this bipartisan, bicameral bill, we can give providers and patients the ability to reduce the amount of unused opioids that remain in medicine cabinets. Inside doctors' offices and exam rooms, those patients should have the authority to manage their prescription and limit the amount of drugs that may end up forgotten in their homes for years. When 70% of all adults who misuse opioids obtain them through loved ones, this legislation is one way for us to combat drug diversion and one step to bolster our prevention efforts. It is as yet another way we can honor Kelsey's memory and continue to fight for her and the millions of other Americans battling this disease. I urge my colleagues to support this amendment in nature of the substitute, and I yield back.
Chair thanks the gentleman. This is a bipartisan amendment, which we support. Are there any other members seeking recognition on this amendment? The question now occurs on the Kennedy amendment to H.R. 4599. All those in favor of the Kennedy amendment say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is agreed to. Are there any other amendments to the bill? Does anyone seek recognition on the amended bill? If not, the question now occurs on forwarding H.R. 4599 as amended to the full committee. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is agreed to. All right. The next bill, H.R. 4976, the Opioid Review Modernization Act. Chair calls up H.R. 4976 and asks the clerk to report.
H.R. 4976, to require the Commissioner of Food and Drugs to seek recommendations from an advisory committee of the Food and Drug Administration.
Without objection, the first reading of the bill is dispensed with. The bill will be open for amendment. Any points so ordered? Are there any bipartisan amendments to the bill? Are there any amendments to the bill? Chair recognizes Mr. Lance to speak on the bill.
Thank you, Mr. Chairman. I move to strike the last word.
Chair recognizes.
I am working on this legislation with our colleague from the Hudson Valley, Sean Patrick Maloney. The bill will help address the rampant opioid and drug abuse epidemic by reforming and improving the medical drug approval and labeling process at the Food and Drug Administration. The bill will ensure that the FDA rigorously reviews the benefits and risks of opioid pain medications, and the benefits and risks are communicated to prescribers and patients. Finally, the bill encourages the development and approval of opioids with abuse deterrent properties. The FDA has a critical role in combating the nation's abuse crisis while also ensuring that patients with pain have access to the therapies they need. This is just one piece of the puzzle, obviously, but I believe it is an important measure that will help us address the overall crisis, and I urge support of this measure, and I yield back the balance of my time.
Chair, thanks, gentlemen. Anyone else seeking recognition? If not, the question now occurs on forwarding H.R. 4976 to the full committee. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is agreed to. Chair now calls up. Where's the number of the bill?
It's a discussion draft.
A what?
It's a discussion
A
draft.
discussion draft?
Just read the title.
Chair calls up the Examining Opioid Treatment Infrastructure Act of 2016 and asks the clerk to report.
Discussion draft, to direct the Comptroller General of the United States to evaluate and report on the inpatient and outpatient treatment capacities, availability, and needs of the United States.
Without objection, the first reading of the bill is dispensed with. The bill will be open for amendment. Any point so ordered. Are there any bipartisan amendments to the bill? Are there other amendments to the bill? Yeah. The chair recognizes gentleman, Mr. Pallone, to speak on the bill.
Thank you, Mr. Chairman. As we know, the opioid epidemic is nothing short of a public health crisis. In 2014, prescription painkillers were involved in 18,000 overdose deaths, and heroin was involved in an additional 10,000. Roughly 2 million Americans live with a prescription opioid addiction, while 467,000 Americans are addicted to heroin. Unfortunately, I don't think that we have reached the apex of this crisis. Last year, deaths from prescription drug overdoses increased by 9%, while deaths from heroin overdoses increased by 26%. But these numbers paint only a partial picture of the heavy toll of this epidemic on our society. Throughout this country, countless families and communities have been shattered by opioid abuse, misuse, and addiction. And I think it's time that we truly pursue best practices to reverse this problem and improve our ability to identify and treat people with substance abuse disorders. In 2013, for example, only one in 10 Americans with a substance abuse disorder received any form of treatment, and that's completely unacceptable, and we should be asking why so few Americans are accessing the treatment they need. Unfortunately, research also indicates that the majority of people in need of treatment for substance abuse disorders do not receive anything that approximates evidence-based care. As we've heard from a number of experts who have testified before this committee, a majority of individuals who receive treatment for substance use disorders are receiving care that is ineffective, outdated, and not evidence-based. Each day we're losing lives because of our inability to provide the treatment capacity necessary to deal with the epidemic. And that's why I'm supporting this bill, which directs GAO to evaluate and report on the inpatient and outpatient treatment capacity, availability, and needs of the United States. It directs the agency to examine treatment capacity for substance use disorders across the continuum of care, as well as to examine the availability of treatment options based on reliable scientific evidence of efficacy. A comprehensive survey of our treatment infrastructure will help us to understand where there are gaps and what we can do to address them. And so I urge my colleagues to support this legislation so we can receive the results of this study for further committee action. I yield back.
Chair, thanks, gentlemen. Anyone else seeking recognition on the bill? If not, the question now occurs on forwarding the Examining Opioid Treatment Infrastructure Acts of 2016 to the full committee. All those in favor say aye. Aye. Those opposed, no. Ayes appear to have it. The ayes have it, and the bill is agreed to. All right, finally. Chair calls up the Opioid Use Disorder Treatment Expansion and Modernization Act and asks the clerk to report.
Discussion draft to amend the Controlled Substances Act to improve access to opioid use disorder treatment.
Without objection, the first reading of the bill is dispensed with. The bill will be open for amendment.
Mr.
at any
Chairman?
point. So ordered. Who's seeking recognition? The chair recognizes Dr. Bouchon
I move to strike the last word.
for 5 minutes.
First, I'd like to ask unanimous consent to introduce for the record a letter from the American Society of Addiction Medicine urging swift passage of this bill.
Without objection, so ordered.
I'd also like to introduce a letter of support from the Harm Reduction Coalition.
Without
Unanimous.
objection, so ordered.
And then thank the American Medical Association, the American Association of Nurse Practitioners, the American Academy of Physicians Assistants, and the American Nurse Association for their support. The opioid epidemic has left no area of this nation untouched. Just yesterday, a local newspaper in my district reported that in one small city, 31 of our fellow citizens lost their lives due to opioid-related overdose last year. The evidence is clear that this epidemic is growing, and it will continue to grow unless immediate action is taken. As a doctor, a father, and a public policy maker, I want to do my part to help our communities overcome this challenge. That's why I'm proud to offer H.R. 4981, the Opioid Use Disorder Treatment Expansion and Modernization Act, today with my colleague, from New York, Mr. Tonko. Together, we've worked day in and day out over the past few months to find common ground and move forward on this important issue. Our final bill represents months of stakeholder engagement and bipartisan work to improve the treatment of opioid addiction and limit drug diversion. Our legislation increases access to opioid addiction treatment where it is needed most by lifting prescribing caps in a responsible and measured manner. It empowers physicians through education, training, and quality of care measures, allowing them to make informed decisions in the prescribing process for opioid use disorder treatment. It also encourages a multi-pronged approach to opioid use disorder treatment by providing physicians and patients education on a wider range of treatment options. It also deters bad actors both on the prescribing side and the patient side by implementing physician-crafted diversion control plans to rein in the abuse and overprescription epidemic. Again, I want to thank Mr. Tonko and all those who have worked with us throughout this process, and I look forward to H.R. 4981's passage here in full committee and on the House floor. I yield.
Chair, thanks, gentlemen. Are there any other amendments?
Mr. Chairman, I have an amendment at the desk.
Okay. Do you want to speak first? In general. Okay, let's go to the amendments and then we'll speak. Dr. Bouchon, clerk report.
Amendment to the discussion draft offered by Mr. Bouchon.
All right. The chair recognizes Mr. Bouchon in support of his amendment.
Thank you, Mr. Chairman. My amendment just makes technical changes to clarify the intent of existing provisions within my bill. I urge its adoption, and I yield back.
All right. The gentleman offers the amendment. We support this amendment. Does anyone desire to speak on the amendment? On this amendment? Okay, we'll go wait for the bill. Okay, on the Bouchon amendment, all those in favor of the Bouchon amendment to the Opioid Use Disorder Treatment Expansion Modernization Act will say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the amendment's agreed to. To offer an amendment, Dr. Murphy.
Thank you, Mr. Chairman. Mr. Chairman, I'm going to offer an amendment withdrawal, but basically it changes the level from 250 to 200. And I know that there's no bigger advocate of trying to do the right thing for dealing with opiate abuse than Dr. Bouchon. I have nothing but admiration for him. I wanted to point out a couple of concerns that have come up in hearings under this Subcommittee of Health, but also under Energy and Commerce's Oversight and Investigation Committee. One is an exchange I had with Dr. Richard Frank, who's the Assistant Secretary for Planning and Evaluation back in October of 2015. When I was asking about, in looking at dealing with a possibility of raising the number of patients a provider could be prescribing for, he asked about such questions as how much time does a doctor spend with each patient? What kind of counseling do they get? Are they in therapy? Are they following through on this? Are they really engaged in treatment? And basically, the answer was they did not know. We had also heard stories where sometimes the actual counseling was someone sitting in the waiting room and calling that group therapy while the patients were waiting to have their time with the doctor. And asked a question of how much time such persons actually spend with the doctor while they're getting their prescription written. Heard some stories from some clinics where it's a minute and a half or 2 minutes, and not exactly what we should be doing. So to that end, certainly Mr. Frank said he shared our concerns and said Secretary Burwell shared their concerns too, and that we need to have a careful approach in addressing these evidence-based treatments. On October 7th, I should also say several members of Congress sent a letter to Secretary Burwell asking her a number of questions about how we track the data when someone is providing these prescriptions. This was October 7th. I'd like to offer this for the record if I could. We have not received a response yet, but I know that Secretary Burwell tries to be pretty responsive and hope that we could still be involved in some discussion on this.
Without objection, so ordered.
I also like to offer an article here that appeared out of an NIH public access, but it was originally from Journal of the American Medical Association in 2012. The article was titled Patient Satisfaction Prescribing Prescription Drug Abuse and Potential Unintended Consequences. Now, this one did not specifically deal with the issue of increasing the amount of, or the number of patients in medication-assisted treatment, but it did raise some very important questions, such as when there is an incentive for a prescriber, particularly from patient satisfaction surveys, there is a concern that has been associated with higher prescribing amounts of opiates. For example, they're saying that given that compensation favors interventional procedures and high patient volume rather than time-consuming discussion, many physicians may behave in a way even they think is questionable, write their requested opioid prescription and move on. It also said non-fulfillment correlates to patient dissatisfaction, which can translate to lower treatment satisfaction scores. It also said a portion of physicians' compensation may depend on the quality of services provided, part of which may be based on patient satisfaction targets. Patients can report dissatisfaction based on real or perceived problems, including whether a clinician did or did not prescribe a desired medication. In some institutions, the first question on the patient satisfaction survey queries the extent of agreement with the statement, quote, "I was satisfied with the way the doctor treated my pain," unquote. It goes on to say that there are powerful disincentives for physicians to provide medically correct care and could contribute to some of the erosion of the trust needed in healthy patient-physician relationship. I raise these as issues that I hope as this bill moves forward between the subcommittee and committee, that we make sure we're working with HHS to make sure we have some much needed questions raised and answers to them of the impact of increasing these numbers, what kind of time is spent between the physician and patient, are they really getting treatment? We know that buprenorphine is the third most diverted drug, and people oftentimes get their prescription, they buy other drugs and take it. We don't know if patients are getting drug tested to see if they're taking other opiates and bypassing the system. I know that there's many physicians out there who are doing a tremendous job with a great deal of care and compassion in their heart, trying to do the right thing, and they can handle these numbers well. I also know that given the questions we raised last year, just last fall with HHS, and we have not received answers to these yet, I'm still concerned we don't have answers, and raising this number could have some unintended consequences. So at that, Mr. Chairman, I'd like to offer these articles, one from Time Magazine of April of this year and one from the Journal of Medical Association, along with the Secretary, if you'll accept them.
Without objections, they're entered into the record.
Thank you, and I look forward to working with you, Mr. Chairman, the Chairman of the full committee, and Dr. Bucshon on this. And Dr. Bucshon, I don't know if you have any comments, but I'll leave it at that then.
I don't. Thank you, and I look forward to working with you.
Thank you.
And you withdraw the amendment.
Withdraw the amendment.
Chair thanks the gentleman. Are there other amendments? Mr. Pallone? You have an amendment. Yeah. She wants to speak on the now?
Yes.
All right. The chair recognizes Ms. Capps. 5 minutes, strike the light.
Thank you, Mr. Chairman, and I move to strike the last word. The Opioid Use Disorder Treatment Expansion and Modernization Act represents months of work across the aisle, across the Capitol, to find effective solutions to help people with opioid addiction access the best treatments available. And I want to thank the authors of this legislation, Mr. Bucshon and Mr. Tonko. We know that to combat the opioid crisis, we need to support all avenues of prevention, treatment, and care, including access to medication-assisted treatment. Today, federal law needlessly prohibits nurse practitioners and physician's assistants who are otherwise permitted by their states to prescribe Schedule 3, 4, or 5 drugs from doing so to address opioid abuse. This is despite the fact that these professionals and their prescribing abilities are traditionally regulated at the state level. The bill before us would fix this discrepancy and allow these valuable healthcare providers to join the fight against opioid abuse, in line with their current prescribing allowances determined by their own states. We will be making progress by expanding the number of healthcare providers able to help folks who need this kind of treatment. The need for medication-assisted treatment is greater than the number that can be treated by certified physician providers, and that is a fact. Americans are suffering because they cannot find a healthcare provider to treat them with buprenorphine. That is a fact as well. We have a solution in the Opioid Use Disorder Treatment Expansion and Modernization Act. So I urge my colleagues to support access to treatment and to knock down artificial barriers to care once and for all. And I'm happy to yield back.
Would the gentlelady yield?
Chair, thanks.
I would yield.
Then I won't need to seek my own time. I thank the gentlelady for her comments. I want to thank both Dr. Bucshon and Mr. Tomko. They've worked together. This is truly a bipartisan bill. I know that on the desk there are a number of amendments that both raise and lower the caps, and I've had discussions with Dr. Murphy last night and suggested to him that I think we've struck the right balance, knowing that we've got amendments that go up and down. And I look forward to continuing to listen before we get to full committee, see if we did get the right level or not. But I'd like to think that the amendments that either raise or lower the caps might be either not offered or withdrawn after we discuss them. And we'll continue to listen between now and when we get to full committee next week. But I'd like to think that this is the right balance and that we can proceed without further amendment to this. And yield back. I thank the gentlelady for her time, and again, I want to thank the two colleagues on both sides of the aisle for pursuing this and moving it forward. And I yield back to the gentlelady from California.
Chair thanks the gentleman. The chair now recognizes Mr. Pallone to offer an amendment.
Thank you, Mr. Chairman. I'd like to offer an amendment. Do you have my amendment at the desk?
Clerk will report Pallone amendment.
Amendment to discussion draft offered by Mr. Pallone.
Chair recognizes Mr. Pallone, 5 minutes on this amendment.
Thank you, Mr. Chairman. This amendment is simple. It would increase the cap on the number of patients physicians can treat at a given time with buprenorphine to 300. While I would prefer to eliminate the cap entirely or adopt the 500 patient cap that passed the Senate Help Committee with bipartisan support, I'm offering an amendment to increase the cap to 300 because I believe that's a fair and reasonable level and should be a level that we can support on a bipartisan basis. We all know the numbers. Each day, 78 Americans die from an opioid-related overdose. Between 1999 and 2010, the death rate from prescription opioids more than quadrupled. We also know the sad reality that this epidemic continues to worsen and those numbers continue to climb each year. We have all learned from our constituents the tragic consequences of this epidemic. And such is the story from one of my constituents from Old Bridge, New Jersey. She had already lost one son to the opioid epidemic and has had to fight to find substance abuse treatment services to save her remaining son's life as he suffers from his own opioid use disorder. And it is seemingly endless stories like hers that compels us to do all that we can to provide the tools necessary for individuals, families, and communities to combat the opioid abuse crisis. The very existence of a cap on the number of patients a provider can treat with a particular medication, I think, is nonsensical. In every other area of medicine, we trust healthcare providers to manage their patient load responsibly. In this instance, we're not trusting doctors who are on the front lines of this crisis to use their professional judgment in order to provide treatment for individuals facing the battle of their lives with opioid addiction. Moreover, these physicians are either addiction specialists or doctors who have taken specialized training to treat patients struggling with addiction, and we still aren't trusting them. Why are we asking these doctors to operate with one hand tied behind their back, possessing the skill and knowledge to help improve a patient's health and potentially save their life, but imposing an arbitrary numerical cap on the number of patients they can treat? I just don't think it makes any sense. The entire DATA 2000 framework smacks of stigma and prejudice against people with substance use disorders. Proposals to ration or limit the amount of prescription drugs a provider can dispense for any other medical condition would be uniformly met with consternation from members on both sides of the aisle. But we treat addiction differently because society continues to view it as a moral failing or a flaw of character rather than as a medical condition and a chronic disease. And I think it's time for our attitudes and for this outdated statutory regime to catch up with the science. While expanding access to buprenorphine must include allowing nurse practitioners and physician assistants to prescribe buprenorphine, this expansion does not lessen the need for a higher cap for physicians. According to the written testimony on the TREAT Act provided by Dr. Waller to this subcommittee, nearly half of those surveyed by the American Society of Addiction Medicine had wait lists of over 100 patients in 2013. The crisis has gotten worse since then, so I can only imagine that wait lists have gotten longer as well. While including nurse practitioners and physician assistants will expand access to treatment, particularly in medically underserved communities, I don't think it's safe for us to assume that the new nurse practitioners and physician assistants capacity will be the same communities with physicians with those wait lists. That means that we could pass legislation and still leave individuals on wait lists that could mean the difference between a patient's family supporting their loved one through their treatment and recovery, or a family member preparing an obituary for that loved one who died as a result of an opioid overdose. And I believe promoting the public health should push us to reject that outcome. Although I would prefer to eliminate the arbitrary cap on buprenorphine prescribing limits altogether, I think a cap of 300 is a fair increase and will improve our ability to respond to this crisis, and I urge my colleagues to support this amendment. I yield back, Mr. Chairman.
Chair, thanks to the gentleman. Anyone else wish to speak on the Malone amendment? Dr. Bashan?
Mr. Chairman, I'm going to speak in opposition to the amendment. The administration listened to all the same viewpoints that we have, and they landed at a number of 200. As we see today, some people want the caps at 200 or lower, some at 300 or higher. As part of our good faith effort to reach a compromise, we went even further than HHS to 250, and the Secretary maintains the authority to change the cap however she sees fit. As HHS said, their goal is to increase access and minimize diversion while providing high-quality care. That is our goal as well. They walked through how they arrived at their number with staff from both sides of the aisle, and it's obvious that they did their homework. Again, to maximize patient care and limit diversion, a number of 250 is a good place to be. We've worked in a bipartisan, transparent fashion for months, and I again believe a reasonable compromise has been reached. I would ask Representative to withdraw his amendment.
I'm sorry, I'm not withdrawing the amendment.
Okay, thank you. In that case, I would urge my colleagues to vote no on this amendment, given the extensive bipartisan hard work put into this piece of legislation and the compromise that has been reached. I yield.
Chair thanks the gentleman. Does anyone else wish to speak on the Malone amendment?
Mr. Chairman, I'd like to.
Chair recognizes Mr. Green.
Just strike the last word. I've heard the arguments about the average capacity of methadone providers should determine a cap for butyric providers. While I understand that treatment setting is the most readily available data can inform this discussion, is the most closely related treatment setting to office-based setting that prescribed. There are some critical differences that must be considered. Methadone is a Schedule II drug, whereas butyric is a Schedule III drug, and it does not have the high risk of methadone. Methadone can cause life-threatening respiratory depression. Such risk supports the delivery of methadone in a highly structured clinic with additional controls and standards not usually provided in a physician's office. Patients receive prescriptions to take butyrophene at home, while many, I'm going to pronounce it every way I can. Most patients must physically go to a methadone treatment facility each day to receive their dosage. I think these are important differences we must keep in mind when trying to analogize the methadone treatment framework to the butyrophene treatment framework. Additionally, I think it's fairly ironic that my colleagues suddenly conveniently choosing to side with the president on this issue. I cannot recount the number of hearings we've had and votes we've taken that make clear that the administration opinion means so little to my Republican colleagues. But again, the Senate bill actually has 500, and I think between 250 and 300 to 500 is probably a pretty good compromise. With that, I'm glad to support Mr. Palone's amendment.
Chair thanks the gentleman. Anyone else seeking recognition?
I might ask that
Malone
the
amendment?
previous gentleman might be able to revise and extend his remarks so we know exactly what those words were.
How many ways do you want me to pronounce it, Fred?
Do you want a recorded vote?
No.
No. All right. The question now occurs on the Malone amendment to the Opioid Use Disorder Treatment Expansion Modernization Act. All those in favor say aye.
Aye.
Those opposed, no. No. The noes appear to have it. The noes have it. The bill's agreed to. All right. The question, are there any other amendments?
Not agreed to. The amendment is
The amendment is not agreed to. I'm sorry. Are there any other amendments to the bill? If not, the question now occurs on forwarding the Opioid Use Disorder Treatment Expansion and Modernization Act as amended to the full committee. All those in favor say aye. Aye. Those opposed, no. The ayes appear to have it. The ayes have it, and the bill is agreed to. Without objection, staff is authorized to make technical and conforming changes to the legislation approved by the subcommittee today. So ordered without objection. The subcommittee markup stands adjourned.